Imagine walking into a clinic after just suffering from devastating, unremitting daily headaches for years. Like you've tried every medication, you've altered your diet, changed your pillow, done all the physical therapy, and nothing works.
Yeah, that level of desperation it's all-consuming for patients.
Right. You are totally desperate. So the doctor looks at your chart, nods, and offers this solution that sounds, well, remarkably high tech, right? Radiofrequency ablation, or RFA.
Right, which sounds very clinical and clean.
Exactly. They tell you they're going to use targeted radio waves to, quote, quiet the nerve. I mean, it sounds elegant. It sounds like you're just turning down a volume dial on a stereo.
It does. But, the terminology we use in medicine can sometimes, well, it sanitizes the reality of the intervention.
Yeah, because here's the massive plot twist in this whole medical detective story we're diving into today. They aren't turning down a dial.
No, not at all.
They are taking a needle, placing it literally millimeters from vital structures in your spine, and heating the tissue to 80 degrees Celsius. They are intentionally inflicting a severe structural burn on your nerve architecture.
Right. When we say ablation, we're talking about deliberate tissue destruction. I mean, for anyone navigating the incredibly complex, often frustrating world of chronic head and neck pain, understanding the reality of what happens beneath the skin is just paramount.
Absolutely. And that's our mission today. If you or someone you love is dealing with chronic pain, you know that desperation for a quick fix. So in this deep dive, we are pulling from a comprehensive clinical reference resource produced by a migraine surgery specialty center. It's titled Radiofrequency Ablation for Headache Disorders.
Yeah, and our goal here is to unpack the entire life cycle of this procedure. We need to look at its history, the frankly brutal physics of how it alters your internal wiring, and the crucial distinction between a nerve that is intrinsically damaged versus one that is merely extrinsically compressed.
Because while RFA can, and it does, to be fair, provide meaningful temporary relief for a lot of patients, it permanently alters your neural landscape.
Exactly. It changes the physical structure of your anatomy, which, inherently changes the options you have available down the road. The stakes here are incredibly high.
They really are. So let's start by looking backward, because the historical context of how we arrived at, burning nerves in the neck and head is fascinating. It didn't actually start with pension headaches, right?
No, it started with something far more extreme. To trace the origins, we have to look back to the 1950s and 60s, focusing on a condition called trigeminal neuralgia.
Okay, what is that exactly?
So the trigeminal nerve is the fifth cranial nerve, and it provides sensation to your face. When it misfires, patients experience this agonizing electric shock-like facial pain. I mean, it is widely considered one of the most severe pain conditions known to humanity.
Oh, wow. That sounds horrific.
It is. So at the time, researchers like William Sweet and James Wepsick were looking for a way to intervene. They published landmark work on radiofrequency rhizotomy, essentially establishing a thermal model for pain control.
So they were dealing with a nerve that was practically screaming, and the goal was to just cut the wire entirely.
Right. But instead of using a scalpel, they used heat. The underlying principle was to use controllable, titratable thermal energy to coagulate the nerve. Their target was the Gasserian ganglion, which is basically the major sensory hub for the trigeminal nerve.
And what were they hoping the heat would do?
Well, their hope was to destroy the specific fibers transmitting the pain signals, while sort of partially preserving the fibers responsible for basic touch and motor function.
I have to point out the bluntness of this foundational idea. I mean, the goal was always destruction. There was no pretense of, healing the nerve or fixing the root cause. It was purely a search and destroy mission for the pain signal.
Yeah, that underlying philosophy of destruction is basically the DNA of the procedure. But, as you know, clinical medicine rarely stays confined to its original application.
Right. Things creep.
Exactly. By 1974, a researcher named C. Norman Shealy and his colleagues took this technique and applied it to the lumbar spine. They began performing lumbar facet joint denervation.
Wait, so from the face to the lower back?
Yes. It was an attempt to silence the nerves carrying pain signals from the arthritic joints in the lower back. And it became a wildly popular intervention for chronic back pain.
Okay, I'm trying to follow the clinical logic here. We start in the face, targeting extreme electric shock pain. Then we jump all the way down to the lower back.
Yeah.
How on earth did this leap back up to the delicate nerves of the neck and head for headaches? I mean, it feels like we're just throwing a dart at the nervous system.
It does seem that way. But the migration up the spine was driven by a changing understanding of headache origins. Throughout the 80s and 90s, the pain management community began to recognize that many chronic headaches weren't just spontaneously happening in the brain.
They were coming from the neck.
Right. They were cervicogenic. They were originating from mechanical issues in the cervical spine and radiating upward. So interventional pain specialists logically took the tools they were using on the lumbar spine and began applying them to the upper cervical spine, targeting the C2, C3, and C3, C4 facet joints.
And the main target there was a nerve that we're going to talk about a lot today, right? The third occipital nerve, or the TON.
Yes, the TON.
Yeah.
The clinical validation for targeting it came heavily from a series of studies in the 1990s, often called the LORD series. They gained huge traction after being published in journals like the New England Journal of Medicine.
And what did they find?
Lord and his colleagues demonstrated that if you could diagnose a cervicogenic headache by temporarily numbing the third occipital nerve with a local anesthetic block, you could then provide longer-term relief by ablating that same nerve with RFA.
Okay, I have to push back on this progression because looking at the history, it's astonishing. We took a technique meant to completely sever communication in a specific screaming facial nerve, moved it to the lower back, and then thought, hey, let's try this on the neck to treat headaches.
It's quite elite.
It really is. It sounds like using a blowtorch to fix a flickering light bulb. You aren't tightening the bulb, you're just melting the fixture so you don't have to look at the flicker anymore.
That's a great analogy. The blowtorch analogy really captures the destructive nature of the tool. But perhaps a better way to frame it mechanically is cutting the alarm wire to a burning building.
Oh, I see. You silence the siren.
Right, which provides immense relief to the person listening to it. But the fire itself, the underlying mechanical issue causing the nerve to fire, is completely ignored.
That makes total sense.
And, the application didn't stop at the neck. Driven by patient demand and clinical desperation, practitioners began applying RFA to the greater occipital nerve and other peripheral branches for occipital neuralgia.
Which is that pain shooting up the back of the head.
Exactly. By the early 2000s, this was in widespread use, despite the evidence base for the head being, frankly, significantly less robust than the data for the spine.
Before we get into the exact mechanics of the burn, I want to ask about a variation that popped up in the 90s. Pulsed RFA, or PRF. Because when you read the literature, PRF is often pitched to patients as the gentler alternative, right?
Yeah, pulsed radiofrequency was introduced as an attempt to harness the electrical field effects without causing the devastating thermal destruction. Conventional RFA heats the tissue to 60 or 80 degrees Celsius, which is fatal to the cells.
Right.
But pulsed RFA delivers short bursts of high-frequency energy, typically for about 20 milliseconds, followed by 480 milliseconds of electrical silence. That long pause allows the heat to dissipate, keeping the tissue temperature below 42 to 45 degrees Celsius.
So the theory is that the electrical field itself does something to the nerve without actually cooking it. It's pitched as neuromodulatory rather than destructive. But how does that even work?
The honest clinical answer is that the mechanism remains pretty poorly understood. The theory is that the high-voltage electrical fields alter gene expression within the nerve cells, sort of down-regulating pain-signaling pathways without destroying the physical architecture.
Okay, but does it actually hold up in practice?
Well, according to the source material we are reviewing, the evidence for pulsed RFA in headache disorders remains highly limited and inconsistent. The data simply isn't robust enough to make it the gold standard.
Which is why the vast majority of these procedures still rely on conventional destructive thermal RFA, the blowtorch.
Exactly.
Okay, so if we're dealing primarily with conventional RFA, we really need to understand the mechanism of action. What exactly is happening to the tissue when that machine is turned on?
The physics of the procedure are actually quite elegant, even if the biological result is brutal. It utilizes a high-frequency alternating current, typically in the range of 300 to 500 kilohertz. This current is delivered through a specialized insulated needle that has a tiny, uninsulated active tip.
And the physician uses imaging to place that tiny exposed tip right next to the target nerve.
Precisely adjacent to it, yes.
Let's clarify something important about that needle, though. It doesn't act like a hot poker. The needle itself isn't generating the heat internally and then touching the tissue.
That is a critical distinction. The needle acts as an electrode. The high-frequency alternating current flows from the uninsulated tip into the surrounding tissue. Because the current is alternating hundreds of thousands of times per second, it causes the ions in the tissue to oscillate rapidly.
Wait, the ions in the patient's own tissue?
Yes. This intense ionic agitation generates friction at the molecular level, which in turn generates heat. The tissue actually heats the needle, not the other way around. It's known as resistive tissue heating.
Oh, wow. And the temperatures we're talking about are severe. The machine brings the tissue temperature up to between 60 and 80 degrees Celsius, and the physician holds it there for a full 60 to 90 seconds per lesion.
Just to contextualize those numbers, normal human body temperature is 37 degrees Celsius. Cell death begins to occur rapidly at temperatures above 45 degrees. At 60 to 80 degrees, you are inducing immediate, irreversible protein denaturation.
Let's break down protein denaturation because I really want you, the listener, to visualize this. You are taking the fluid, dynamic, organized proteins inside the nerve and essentially cooking them. It is exactly like dropping a raw, clear egg white into a hot frying pan, isn't it?
It is functionally identical. The heat breaks the chemical bonds and the proteins tangle and solidify, turning that clear liquid into a hard, opaque mass. The medical term for that exact transition is coagulative necrosis.
So the nerve is just cooked.
Yes, the organized cellular architecture of the nerve is totally obliterated. The myelin sheath, the fatty insulation wrapping the nerve melts. The axon, the actual wire transmitting the signal, is disrupted. The nerve entirely loses its capacity to transmit action potentials. It is functionally dead in that specific zone.
This is why we have to differentiate this from a nerve block. When a patient gets a nerve block, they are getting an injection of, like, lidocaine. That chemical just temporarily blocks the sodium channels, it wears off, and the nerve is perfectly fine.
Exactly. RFA is not a long-lasting nerve block. It is deliberate structural destruction.
And the intended goal of this destruction is to target specific fibers, right?
Yes, the small diameter nerve fibers. In neuroanatomy, pain is primarily transmitted by A delta fibers, which carry sharp, fast pain, and C fibers, which carry slow, aching pain. Because they are smaller, the theory was that they might be more susceptible to thermal damage.
But heat is a blunt instrument. I mean, it doesn't have a targeting system that only seeks out the pain fibers.
That is the unintended consequence. The heat is entirely non-selective. While you are destroying the A delta and C fibers, you are also obliterating the larger A alpha and A beta fibers within that same nerve bundle.
And what do those larger fibers do?
They're responsible for proprioception, light touch. You are wiping out the entire communication highway, not just the pain lane.
That's terrifying. And the geography of this destruction is incredibly localized, right? The text notes that the thermal lesion created by a standard needle with a 5 to 10 millimeter tip is an ellipsoidal shape. It's roughly 5 to 10 millimeters in diameter. That is smaller than a peanut.
The size of the lesion highlights why image guidance is absolutely paramount. For deep structures, physicians rely on fluoroscopy, continuous X-ray, or CT guidance. For superficial peripheral nerves, they use high-resolution ultrasound.
But think about the margin for error here. You are trying to drop a peanut-sized burn zone onto a nerve that might be a millimeter or two thick, buried under layers of muscle and fascia. If your needle placement is off by just a few millimeters,
You could completely miss the target nerve, leaving the pain intact while happily coagulating healthy adjacent muscle tissue.
or, far worse, you could inadvertently heat a motor nerve, right, and compromise muscle function.
Yes, the reliance on perfect anatomical placement is why the clinical outcomes are so heavily dependent on the skill of the operator. Even with perfect imaging, the spread of the thermal energy can be affected by local tissue impedance or blood vessels acting as heat sinks.
Which naturally leads us to ask, where does this actually work? If we have this highly destructive, incredibly precise, yet easily misplaced thermal tool, what does the evidence say? Because the reality is, patients are getting this done all over their heads and necks.
Well, the clinical evidence is not a monolith. It varies wildly depending on the anatomical target. The source material categorizes the clinical indications into 4 distinct tiers of evidence: strongest, moderate, limited, and insufficient.
Okay, let's examine the strongest tier first. Where does the data unequivocally support burning the nerve?
The most robust evidence exists for targeting the third occipital nerve, the TON, to treat cervicogenic headaches originating from the C2-C3 facet joint. In rigorously controlled trials, clinicians see a 70 to 88% response rate in appropriately selected patients.
A near 90% success rate is staggering in chronic pain management. But that success rate hinges entirely on that phrase you just used, appropriately selected.
Exactly. The non-negotiable prerequisite for that level of success is a positive diagnostic nerve block. A patient must undergo a block using a local anesthetic on that specific nerve.
So if the headache completely resolves while the anesthetic is active, that confirms the nerve is the problem.
Yes, it confirms the anatomical pain generator. The literature is extremely clear. Patients who only respond to placebo injections or who have ambiguous block results should absolutely not proceed to radiofrequency ablation. The diagnostic block is the compass. Without it, you are burning blind.
Okay, so moving down the tier list, we hit moderate evidence.
This applies to the upper cervical medial branches, slightly higher up the spine at the C1, C2, and C2, C3 levels. The anatomy here is far more complex and variable, but the data generally supports RFA for posterior headaches originating from these joints, with response rates between 60 and 80%.
But then the clinical picture gets murky, doesn't it? As we move out of the spine and start targeting the peripheral nerves in the actual head, the evidence drops off. Let's look at the limited evidence category.
Right. This tier covers the greater and lesser occipital nerves for occipital neuralgia. The evidence here is considered limited because while published case series report response rates ranging from 50 to 70%, the rigorously controlled double-blind trials are sparse.
And the criteria for how patients are selected is inconsistent.
Very inconsistent, which makes it difficult to draw universal conclusions.
And then we reach the final category, which frankly I find alarming, the insufficient evidence tier.
This pertains to applying RFA to the nerves in the front of the head and the temples, specifically the supraorbital, supratrochlear, and zygomaticotemporal nerves.
Wait, these are the nerves running right across the forehead and the temples, the exact areas where millions of people experience tension headaches and migraines, and the evidence for burning them is legally and clinically deemed insufficient.
The data supporting RFA for these frontal nerves is primarily limited to anecdotal case reports and very small, uncontrolled series. The anatomical reality is what makes this so precarious. As we move to the front of the face, the nerves become incredibly superficial.
Right, they run directly under a very thin layer of skin, which changes the risk profile entirely. I mean, if you deploy an 80-degree thermal lesion directly under the skin of the forehead, you aren't just risking nerve damage.
No, you are risking visible thermal burns to the skin, changes in skin pigmentation, and severe, highly localized sensory deficits right in the middle of a patient's face.
I have to challenge the clinical justification here, then. If the evidence for zapping the nerves in the forehead is formally classified as insufficient and the risks of superficial burns are that high, why is this procedure so widely available? You can go to almost any major pain clinic right now and they will offer to ablate your supraorbital nerve. Are clinicians just guessing?
It really speaks to the unique, often desperate nature of chronic pain medicine. When you have a patient sitting in your office who has been in daily, unremitting agony for 5 years, and they've failed every pharmaceutical option available, the clinical motivation to provide relief is immense.
So they try whatever they have.
Yeah. The proliferation of interventional treatments frequently outpaces the rigorous clinical trials required to prove long-term efficacy. It is driven by a profound clinical need, but the consequence is that patients are undergoing destructive procedures with a glaring lack of long-term safety data.
Okay, let's follow the timeline for a patient who does fit the best case scenario. Let's say they have a cervicogenic headache. They get the diagnostic block, it works perfectly, and they get the C2, C3 ablation. They fall into that 88% success bracket, they get off the table, the pain is gone, they think they are cured. But there is a massive biological catch, isn't there?
Yes. The relief provided by RFA is built on an illusion of permanence. To understand why the pain inevitably returns, we must dive into the cellular biology of nerve injury, specifically a process called Wallerian degeneration.
Walk us through this microscopic timeline. The burn is complete. What happens to that nerve segment in the days and weeks that follow?
When the thermal energy destroys the structural integrity of the nerve, the entire axon does not instantly die. The burn creates a localized zone of destruction. But the portion of the axon that is distal to the burn, meaning the segment physically severed from the main neural cell body, can no longer sustain itself.
Right.
Within 24 to 48 hours, it begins a programmed cellular death known as Wallerian degeneration.
So the wire downstream from the cut just crumbles.
Exactly. Calcium floods into the damaged axon, activating enzymes called calpains that physically dismantle the internal cytoskeleton. The myelin sheath breaks down into lipid droplets. Over the next few weeks, your body's immune system, specifically macrophages, arrive to basically eat and clear away all this cellular debris.
It's like a microscopic demolition and cleanup crew. But what about the other side of the burn? The proximal stump that is still connected to the brain.
The proximal stump does not die. In fact, it almost immediately shifts its metabolic machinery into an aggressive regenerative state. The Schwann cells begin to proliferate rapidly and form hollow tubes called bands of Bungner, which act as biological tunnels trying to guide the new growth.
So it's actively trying to reconnect.
Yes, At the tip of the severed axon, a growth cone forms, sending out tiny exploratory filaments, searching for a path across the injury site.
The nerve starts growing back. How fast are we talking?
Peripheral nerves are astonishingly resilient. Under optimal conditions, a regenerating axon will grow at a rate of approximately 1 to 3 millimeters per day.
Let's do the math on that, because it is the most sobering calculation a patient can make. 1 to 3 millimeters a day. The thermal burn zone, created by the RFA needle, is only 5 to 10 millimeters wide. Even at the slowest growth rate of 1 millimeter a day, that nerve is crossing the thumble gap in less than 2 weeks.
The physical gap is crossed quickly, yes, but the maturation of the nerve, the remyelination and reestablishing connections, takes months. This is why the clinical data shows that the median duration of pain relief following a successful RFA is typically only 6 to 14 months.
Because the nerve aggressively regenerates, and as it reaches its targets, the pain transmission resumes.
Exactly.
But, the narrative patients often tell themselves is, my headache came back. They view it as a relapse of their original condition, but it's not the original headache, is it?
No, it is a fundamentally different biological scenario. The regeneration process does not restore the nerve to its pristine original state. The regenerating axons face a hostile environment. They have to navigate through the dense, disorganized scar tissue created by the thermal burn.
I want to visualize this. Imagine a perfectly manicured vine growing along a straight trellis. That's your healthy nerve. RFA comes in and burns a massive hole in the middle of the trellis. When the vine tries to grow back, it doesn't just shoot straight across the empty space, it tangles. It wraps around itself. It grows wildly in different directions, desperately looking for the path but getting blocked by the burn debris.
That is an excellent mechanical analogy for biological chaos. In neurology, we call this aberrant regeneration. The axons may fail to find their original endoneurial tubes, and most importantly, the newly formed membrane of these regenerating nerve fibers is often highly unstable.
Unstable how?
They can develop abnormal concentrations of sodium channels, meaning the nerve can begin to spontaneously discharge electrical signals without any external stimulus. It just fires off pain signals on its own.
So you aren't just dealing with the old pain, you are dealing with a new, irritable, regenerating nerve fighting through a burn site, which traps the patient in a cycle, doesn't it? The pain returns at 8 months, so they go back to the clinic and they get another RFA to burn the new growth. They sign up for a subscription of repeated interventions.
And that cycle of repeated burning introduces a compounding array of risks. We have to address the complication profile of RFA. While it is broadly categorized as minimally invasive, the risks are uniquely devastating because they are born from deliberate tissue destruction.
The source material lists standard procedural risks first. Infection, vascular injury because the neck is packed with blood vessels, and even pneumothorax if they're working lower down. But those are mechanical errors. The true dark side of denervation lies in the neurological complications.
The first and most common is post-procedural neuritis. When you inflict an 80-degree thermal burn on a nerve, you trigger a massive local inflammatory cascade. The tissue swells, immune cells rush in.
And that causes pain.
For many patients, yes. It results in a period of intense, increased pain, burning, or hypersensitivity that can last for weeks or even months after the procedure.
It is a crucial warning. You go in desperate for headache relief, and for the first 2 months, your head and neck might actually burn significantly worse than before you walked in.
Clinicians must proactively counsel patients about neuritis so they don't interpret the immediate post-operative pain as a failure. Following neuritis, you have the inevitable sensory deficits. If you ablate a sensory nerve, you inevitably alter sensation.
Like numbness.
Yes, patients frequently experience dysesthesia, abnormal, unpleasant sensations like numbness, tingling, or the feeling of insects crawling on the skin. But a much more common complication arising from that wild vine regeneration we discussed is the formation of neuromas.
Let's define a neuroma, because this isn't just a tumor, it's a structural failure of regeneration.
As those growth cones at the tip of the regenerating axon try to push forward, they rely on the microscopic scaffolding of the nerve to guide them. If that scaffolding has been obliterated by thermal coagulative necrosis and replaced by dense scar tissue, the axons hit a physical wall.
But the body keeps trying to grow.
Yes. So the axons just start coiling up on themselves, tangling with connective tissue, forming a disorganized microscopic ball of highly sensitive exposed nerve endings. That ball is a neuroma.
It's a ball of live wires with no insulation. If a muscle rubs against it, or if you simply press your head against a pillow, it sends a massive ectopic shock of pain straight to the brain.
Precisely. And this is where the cycle of repeated RFA becomes so dangerous. Imagine a patient who gets an RFA. 10 months later, the nerve regenerates aberrantly, forms an neuroma, and the pain returns. The patient assumes their original headache is back, so they get another RFA.
But the anatomy has changed. They're burning into scar tissue now.
The anatomy is entirely compromised. Now, the physician is driving the thermal needle into an area already choked with ischemic scar tissue. They are potentially burning the newly formed neuromas, which triggers an even more chaotic regenerative response.
You are trapping the nerve in a prison of its own scar tissue.
The clinical reality is that there is a hard ceiling to what repeated ablation can achieve. Eventually, the RFA stops providing even temporary relief, leaving the patient in a worse state of intractable pain than when they began.
To truly grasp why the scarring is catastrophic and why it permanently changes a patient's options, we have to zoom in even closer. We need to look at the microscopic architecture of a peripheral nerve. This brings us to the core distinction of this entire clinical resource: the difference between extrinsic compression and intrinsic damage.
If the listener takes away only one fundamental concept from this entire deep dive, it must be the differentiation between extrinsic compression and intrinsic damage. It governs every logical decision in headache surgery.
Okay, let's build a nerve from the inside out to understand this. What does a peripheral nerve actually look like under a microscope?
It is a marvel of biological engineering. It's a highly organized, multi-layered cable. At the absolute center, you have the axon, the delicate projection carrying the electrical signal. Wrapping around that axon is the myelin sheath, a lipid layer acting as insulation.
Axon and myelin, the wire and the plastic coating.
But those wires are fragile, so the body protects them. Immediately surrounding each individual myelinated axon is a delicate microscopic sleeve called the endoneurium. Multiple axons are bundled together into groups called fascicles, and each fascicle is wrapped in a denser layer called the perineurium.
Which gives it strength.
Right. Finally, all those fascicles are bundled together and wrapped in a tough outer protective sheath called the epineurium. And weaving through all these layers are tiny, critical blood vessels called the vasa nervum, which keep the entire structure alive.
We need a mechanical analogy to hold all these layers in our heads. Think of a massive, underground, multi-core fiber optic cable. The epineurium is the thick, black, weatherproof outer plastic pipe. Inside that pipe are smaller protective tubes, the perineurium. Inside those tubes are the tiny endoneurial sleeves. And resting safely in the absolute center are the delicate glass fiber optic threads, the axons carrying the data.
The fiber optic analogy beautifully illustrates the structural hierarchy. Now, to classify how damage affects this structure, neurologists use the Sunderland classification system. It grades nerve injuries on a scale from 1 to 5.
So let's apply this to the two different types of problems a headache patient might face. The first is extrinsic nerve compression. What is happening to the fiber optic cable in an extrinsic scenario?
In extrinsic compression, the nerve itself, the axons, the myelin, all the protective layers, it's perfectly healthy. The internal architecture is pristine. The pain is generated because external anatomical forces are physically squeezing or crushing that normal nerve.
What kind of forces? What in the neck or head is strong enough to crush a nerve?
The most common culprits are chronically contracted hypertrophied muscles. With modern forward head posture from looking at screens, the muscles in the back of the neck are under constant strain. They hypertrophy, meaning they grow thicker and tighter.
And the nerves have to pass through them.
Yes. Nerves like the greater occipital nerve have to physically pierce through these muscle bellies to reach the scalp. When those muscles clamp down, they crush the nerve. Or it could be tight fascial bands or anomalous blood vessels wrapping around the nerve. The nerve is a healthy victim trapped in a hostile anatomical environment.
Going back to our analogy, extrinsic compression is someone stepping a heavy steel-toed boot onto your underground fiber optic cable. The glass fibers inside the plastic pipe are totally fine. They are just getting pinched, causing a transmission error. If you want to fix the problem, you don't cut the cable, you just lift the boot.
That is the perfect logical conclusion. But intrinsic nerve damage, which is exactly what radiofrequency ablation causes, is a fundamental of different pathological state. The thermal energy of RFA does not interact with the tight muscle or the fascial band. It is delivered directly into the nerve itself.
You are taking a high-powered laser, bypassing the heavy boot, and melting the fiber optic glass cores from the inside out.
Exactly. A successful RFA produces a grade 3rd or grade 4th Sunderland injury. It physically destroys the myelin, disrupts the axons, kills the Schwann cells, and most devastatingly, it thermally coagulates the endoneurium, those microscopic guiding tubes. The internal infrastructure is completely ruined.
This is the realization that stops you in your tracks. If you are a patient and your daily migraine is actually being caused by a hypertrophied muscle in your neck pressing on the nerve, undergoing an RFA does absolutely nothing to the muscle. The muscle is still there, swollen, tight, and squeezing.
You haven't fixed the mechanical defect.
You've simply taken a blowtorch and destroyed the internal alarm system that was trying to warn you about the squeeze.
You have rendered the nerve intrinsically damaged, burdened it with thermal scar tissue, while leaving the extrinsic compression completely unaddressed. You've compounded the pathology.
So if the problem is just a boot on the cable, a tight muscle trapping a healthy nerve, what is the alternative to melting the internal wires?
The gold standard alternative, when correctly diagnosed, is peripheral nerve decompression surgery.
This feels like the great reveal of the document. Decompression surgery represents a total paradigm shift in how we think about treating chronic nerve pain.
Decompression surgery is rooted in the principle of restoring anatomical harmony. The surgical objective is to identify and physically release the offending anatomical structure that is compressing the otherwise normal nerve.
So if a muscle is clamping down,
The surgeon makes an incision, locates the entrapment point, and physically dissects and removes the constricting muscle fibers, creating a clear window for the nerve to pass through. If a tight fascial band is acting like a tourniquet, the surgeon sections the fascia. It is about restoring the natural glide planes so the nerve can move freely.
I love the philosophy here. It is a corrective approach, not a palliative one. You aren't trying to mask the pain or punish the nerve. You are physically curing the mechanical defect.
And the clinical outcomes reflecting this corrective approach are profoundly compelling. The clinical reference document explicitly states that for appropriately selected patients, nerve decompression surgery has an up to 93% success rate.
Wait, up to 93%. In the realm of chronic migraines, where patients are routinely told they just have to live with the pain, a 93% success rate is an astronomical number.
It is a transformative success rate. But again, we must emphasize the caveat: appropriately selected patients. Decompression surgery only works if the pain is genuinely caused by extrinsic compression.
So how does a migraine surgeon definitively know if a nerve is compressed before they cut the patient open?
They rely on the exact same diagnostic tool utilized by the pain management doctors: the diagnostic nerve block.
Wait, I need to pause here. The exact same test. The surgeon and the pain doctor both use the local anesthetic block.
Yes. They inject a small volume of lidocaine around the suspected nerve. If the patient's headache dramatically disappears, it proves unequivocally that the specific peripheral nerve is the anatomical driver of the pain. The nerve block tells the clinician where the pain is coming from.
This raises a massive, glaring question. If decompression surgery has an up to 93% success rate, and it actually corrects the root cause without intentionally destroying the internal architecture of the nerve, why isn't this the first line of defense? Why are hundreds of thousands of RFAs performed every year while decompression remains relatively niche?
It comes down to the structural flow of the modern medical system, which leads us to the most urgent warning contained in this entire clinical resource: the sequence problem.
Why the order of operations matters. This is where a patient's unguided choices in a clinic can permanently alter their biological future. Let's dig deeply into this sequence.
The systemic clinical error occurring nationwide is that patients are reflexively funneled from a positive diagnostic nerve block directly into a radiofrequency ablation, without ever being evaluated by a specialist for surgical decompression.
Because they're at a pain clinic.
Right. Patients typically present to a pain management specialist, not a migraine surgeon. The pain doctor performs the block, sees that it works, and utilizes the primary tool available in their specific armamentarium, the RFA needle.
Because if you allow them to burn the nerve first, you permanently alter the tissue in a way that surgery cannot fix.
This is the crux of the issue. A migraine surgeon is highly skilled at lifting a muscle off a nerve. But no surgeon on earth can rebuild the microscopic endoneural tubes that were melted into coagulative necrosis by an 80-degree thermal needle. Surgery cannot reverse intrinsic damage.
So let's run a devastating hypothetical. A patient gets a diagnostic block. It works. They get an RFA. It works for 8 months. The pain comes back wildly due to aberrant regeneration. They get a second RFA. More scar tissue. The pain comes back worse. Finally, desperate, they find a migraine surgeon. What exactly does that surgeon find?
They find a microscopic nightmare. The nerve is still being compressed by the original hypertrophied muscle because the RFA never addressed it. But now, the nerve itself is a rigid ischemic cord encased in dense thermal scar tissue. The nerve might be studded with microscopic neuromas.
Decompressing a pristine, healthy nerve yields that incredible up to 93% success rate. But what happens when you try to decompress this intrinsically destroyed, scarred, regenerating nerve?
The outcomes become vastly less predictable and significantly less successful. Freeing the nerve from the muscle doesn't stop the neuromas from firing ectopic pain signals. Furthermore, the document highlights a severe neurological consequence of this delayed timeline: central sensitization.
We touched on this earlier with deferentation pain, but how does central sensitization specifically relate to the scarred, regenerating nerve?
When a nerve is repeatedly burned and forced to regenerate through scar tissue, it constantly bombards the central nervous system with abnormal ectopic pain signals. Over months and years, this relentless barrage physically alters the dorsal horn of the spinal cord and the pain processing centers in the brain,
The brain's pain dial gets turned up to maximum.
and it gets chemically stuck there. The central nervous system becomes exquisitely sensitive to even normal, non-painful stimuli condition called allodynia.
So if a patient waits too long and undergoes too many RFAs, central sensitization sets in. At that point, even if a surgeon perfectly frees the nerve, the brain might just continue generating the migraine anyway because the central alarm system is permanently broken.
The window for a clean surgical cure has slammed shut, and the source material delivers a highly specific, dire clinical protocol regarding this exact scenario. It notes that for patients who fail RFA therapy, repeated RFA may cause such excessive, irreversible damage to the neural architecture that the surgeon is forced to pivot. They might be required to perform a division rather than a decompression.
Let's clarify what division means in a surgical context because it sounds terrifyingly final.
It is the final option. If the surgeon opens the neck and finds a nerve that is so heavily scarred and studded with so many neuromas that it cannot possibly be salvaged or expected to function normally, they can no longer just free the nerve. Decompression is impossible.
So what do?
They are forced to intentionally sever the nerve completely, to divide it, and bury the proximal stump deep into a muscle belly in a desperate attempt to silence the ectopic discharging forever.
You walk into surgery hoping to have the boot lifted off your fiber optic cable, and the surgeon realizes the cable is so melted and corrupted that their only choice is to take an axe and chop the cable in half, leaving you permanently numb just to stop the static.
That is the grim reality of compounding intrinsic damage, which is why the guidance in this clinical resource is so explicitly urgent.
So we need to speak directly to the patient sitting in a clinic right now. They just got a diagnostic nerve block in their forehead or the back of their neck. It worked beautifully. The doctor walks into the room with a clipboard, smiles, and says, "Great news, the block confirmed the target. Let's book you for a radiofrequency ablation next Tuesday." Based on the evidence we've just unpacked, what should that patient say?
The clinical recommendation is unequivocal. Hit pause. The text strongly advises that it is best to have a consultation regarding decompression migraine surgery before having more than 1 or 2 RFA treatments.
1 or 2. That is the hard limit on the timeline.
1 or 2 RFAs might reasonably be part of a complex diagnostic journey, or perhaps serve as a temporary stopgap measure while waiting for a surgical consultation. The body can often handle one thermal insult and regenerate relatively well. But beyond that limit, the cumulative, disorganized scar tissue builds up exponentially.
You are systematically burning your own bridges to a permanent, elegant surgical fix. It is a massive clinical crossroad, and the tragedy is that most patients don't even know they are standing at it.
Right. You think you are just checking off the next box in a routine pain management protocol, but you're actually making a structural decision that might disqualify you from a cure.
The diagnostic block proves that the nerve is the problem. You then face a fundamental fork in the road. Do you palliate the nerve by structurally destroying it, or do you correct the nerve by mechanically decompressing it? The sequence of those choices matters absolutely.
The ultimate takeaway for anyone listening is empowerment through anatomical understanding. When you understand the microscopic difference between the inside of the nerve and the mechanical environment surrounding the nerve, it changes your entire paradigm. You stop asking, will this stop the pain, and start asking, how is this altering my anatomy to stop the pain?
We've covered an immense amount of ground today, navigating from the origins of trigeminal nerve burns in the 1950s all the way to the microscopic intricacies of Wallerian degeneration and the elegance of modern decompression surgery. We started with the appealing idea of RFA as a magical volume knob. What the evidence reveals is that RFA is undeniably a powerful tool. It provides highly meaningful temporary relief for thousands of desperate people, but we must look it in the eye for exactly what it is physically doing. It is fundamentally destructive.
It induces coagulative necrosis, it inflicts intrinsic damage, it melts the fiber optics from the inside out in exchange for temporary silence.
Extrinsic compression, conversely, is a purely mechanical problem, a heavy boot on the wire. And we now know it has a highly successful, structurally sound surgical solution, featuring an up to 93% success rate, provided that the patient hasn't allowed the nerve to be irreversibly corrupted by repeated thermal burns, forcing a surgeon to abandon decompression and divide the nerve entirely.
It is a testament to why comprehensive patient education is the most powerful intervention in medicine.
Which leaves me with a final thought I want you, the listener, to mull over long after this audio ends. It goes back to our initial medical detective story and our cultural desire for a clean, mechanical fix for human suffering. Think about the sheer astonishing neuroplasticity of the human body. Every single time we intervene in the nervous system, every burn, every cut, every thermal ablation, we force the body to adapt. It tries to heal. It builds defensive scar tissue. The question we must ask ourselves when evaluating these treatments is, are we treating the human body like a simple machine with easily replaceable parts? Or are we finally starting to respect it as a dynamic, deeply interconnected ecosystem that physically remembers every single trauma we inflict upon it? When we burn a bridge in the nervous system, nature will desperately try to rebuild it, but it rarely builds it back the way it was.
This discussion is intended as a source material resource for education, and that medical decisions should always be individualized and based on current evidence-based guidelines and clinical judgment and directed by a physician.